Hello everyone, my name is Lauren Heinecke and I'm an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. And today it's my pleasure to be here talking with you about influenza vaccines. Appropriately, the presentation for today is titled LAIV or Inactive, Nasal or Injection, Quadrivalent or Trivalent, Understanding the Differences in Influenza Vaccines. So we've got a lot of influenza vaccine products available this year, and we're going to specifically go over all those different products and talk about how you're going to determine which product to use for which patient. By the end of our time together, you should be able to outline the Center for Disease Control's Advisory Committee on Immunization Practices recommendations and guidance for the 2013-2014 influenza season. Secondly, you should be able to compare and contrast the different influenza vaccine options. And specifically, we're going to talk about ease of use, as well as the comparative efficacy between the products and the safety profiles of each of the products. And then to finish up our talk today, we're going to outline the pharmacist's role as an immunizer and advocate for vaccinations. So we've got a lot of information to cover, but I think a lot of it will be very helpful for you going into this year's flu season. So everybody who's already attended one of my talks knows that I like to start out with some numbers and the epidemiology of the disease we're talking about. So in terms of influenza in the United States, it's estimated that between 25 to 50 million cases of influenza occur annually in the United States. So a lot of people are affected by influenza. We can affect the number of cases by providing the immunization. Of course, some of the number of cases, even if we have really wonderful vaccination rates, certainly are dependent on our ability to effectively select the strains that are included in the immunization. Certainly last year it wasn't a very good match. I think it was only about 62% effective. So certainly we can't predict that, but by immunizing, we certainly can decrease the number of cases that occur annually in the U.S. In addition to that, influenza-associated deaths really vary substantially by year, and ultimately that's, again, dependent on how well our vaccine is matched up with the circulating strains that year, how many people receive the immunization, and then the virulence of the strains that are circulating. But there's an average of about 23,000 deaths annually, which is a pretty big number considering we could probably prevent some of those if we, really vaccinated as many people as we could. In addition to that, more than 200,000 people are hospitalized for influenza. Certainly that's a lot of healthcare dollars spent on the treatment of people who have more severe influenza. Likely the people that are hospitalized are the very young or the very old. Those are the folks that tend to be more susceptible to influenza and tend to have more complications as a result of being infected with influenza. And then the last item that I'd like to share is that fewer than 20% of people in high-risk groups actually receive the influenza vaccine annually. So I think, when we get into talking about pharmacists' role as immunizers, one of the things we can really do is to be an advocate for those people that we know are at higher risk for influenza in terms of encouraging them to receive the immunization. So let's move into the recommendations from the ACIP group for this year. So specifically, the strains for the 2013-2014 influenza season are different than last year. And you'll notice that the first three that I have bulleted there for you are contained in the trivalent influenza vaccine. So one of the things we're going to be talking about is the trivalent vaccine versus the quadrivalent vaccine. Now, one of the things that I think you're going to see happen in the future is that the majority of your vaccine products are likely going to become quadrivalent, but it takes some time for manufacturers to be able to make these types of modifications. So we still do have, the majority really of our products are going to be trivalent, but I think next year we're going to see many manufacturers switching over to produce quadrivalent vaccine products. So the top three strains are the strains in your trivalent influenza vaccine. The last one, the bottom bullet, is going to be the fourth strain that's going to be included in the quadrivalent vaccine. And so the difference between trivalent and quadrivalent, we'll talk about this a little bit later, is just that there are two different variants. There's the Victoria and the Yamagata variant, and so now with the quadrivalent vaccine you'll have both of those present. We'll talk about why that may potentially be important as we get into comparing the vaccine products. So the general recommendations for influenza vaccine in terms of who should be immunized are that anyone over the age of 6 months should be vaccinated. In terms of the administration of the vaccine, it really should ideally occur prior to the onset of influenza activity. And so really you should be offering the vaccine soon after it becomes available, and if possible by October. I think the other important item to consider is that, so the next bullet is that 2 doses should be administered to children between the ages of 6 months and 8 years. And we'll go into a little bit more detail on the next slide. Not everyone in that age category needs 2 doses, but those 2 doses do need to be 4 weeks apart. And the importance of the 2 doses is really to essentially prime the immune system with the first dose and then to elicit a more robust immune response with that second dose in a child who has not previously been immunized. And so with that more robust immune response after that second vaccine, that child is going to have better protection against influenza. So for those children who do need 2 doses, it would be ideal to get them the first dose of their vaccine as early as possible, to make sure that that second dose, which does, as I mentioned, need to be administered at least 4 weeks after the first dose, is administered as early as possible before we start to see influenza activity. So to touch a little bit more on the 1 immunization or 2 for those children between the ages of 6 months and 8 years, the ACIP, CDC ACIP group has put out this flow sheet to help you determine whether or not the child needs 1 dose or 2 of the vaccine. So the first question you're going to be asking is, has the child ever received the influenza vaccine? If the answer is no, or you don't know, you're going to go ahead and give them 2 doses. And the little asterisk that's present there just indicates that they should be administered at least 4 weeks apart, which I've already mentioned. Now, if you answer yes to that question, they have received the influenza vaccine. The next question is, did the child receive a total of 2 or more doses of the seasonal influenza vaccine since July 1st, 2010? If the answer is no, or you don't know, you're going to again administer 2 doses. If the answer is yes, you're only going to administer 1 dose. Now, you'll notice that there's the asterisk and then there's an additional symbol to the right of the asterisk of the 2 doses. The asterisk, again, is just indicative of needing 4 weeks between those 2 doses of the vaccine. So the importance really is that the child, so if you remember the 2009 H1N1 strain that we saw, really took a pretty big toll on our younger patients. We didn't see as much morbidity and mortality in our older patients, and a lot of that was thought to be due to the fact that the younger group of people hadn't been exposed to that strain before, and so just didn't have as much immunity to it as some of the older folks. So the reason for the additional symbol is that for simplicity, they just talk about they've received a vaccine since July 1st, 2010. So they need to have at least received 1 prior dose of that 2009 H1N1 containing vaccine, which would have been in the 2010-2011 vaccine product, the 2011-2012 vaccine product, and the 2012-2013 season product. So this has really aimed to provide simplicity, but really what you're looking for is that prior to this influenza season, the child has received at least 1 dose of that 2009 H1N1 containing vaccine. And I've already mentioned the seasons during which that would have been present. So hopefully that clarifies the 1 immunization or 2. The majority, I would say, of your younger children who have received the vaccine probably have already received that particular vaccine product. I think as you get into the children who are 7 or 8, if they've never received the influenza immunization before, it's at that point that you're really going to start thinking about maybe giving them 2 doses of the vaccine product. The next item that I wanted to cover that ACIP does a nice job in terms of covering is their recommendations in patients who have an egg allergy. And I do apologize, this is a little bit small to see, but I think it's important to talk about. So again, you're going to go through a list of questions, and depending on the answer, yes or no, it's going to help you determine which of the influenza vaccine products to use. So can the person eat lightly cooked eggs? So for example, scrambled eggs without a reaction. Now the first thing I think that's important to talk about is just with the egg allergy that Someone who has an egg allergy, they may be able to tolerate eggs in baked products such as breads or cakes. And that just tolerance of an egg-containing food doesn't exclude the possibility of an egg allergy. So just to throw that out there. So we're looking for people who have an intolerance when they're just eating the eggs by themselves. So scrambled eggs is a great example. Any other just plain egg product that you could eat for breakfast would be another example. But just an egg-containing product like bread or cake doesn't mean that the person doesn't have an egg allergy. So if they can eat a lightly cooked egg without a reaction, and the answer is yes, then you go ahead and administer the usual vaccine per protocol. So we'll talk about, the different products, and you can determine which product might be best for your patient later on in the talk. If the answer to this is no, the next question is what type of reaction does the person experience? If they experience only hives, and the answer to that is yes, it's only hives, you have a couple of different options, and we're going to talk specifically about the abbreviations that are contained in this slide. I think it's on the next slide or in a couple of slides, but you can administer the recombinant hemagglutinin influenza vaccine. That's what RIV3 stands for. This is a vaccine that's not produced in chicken eggs. It's actually a cell-based vaccine, so there's not going to be any egg component. And you can do this if the patient is between 18 and 49 years of age. That's the age group that the vaccine product is currently licensed in. Or you can go ahead and you can administer the regular inactivated influenza vaccine. So IIV is actually the new abbreviation for trivalent inactivated influenza vaccine. So TIV is going away. And you want to go ahead and observe them for at least 30 minutes following vaccination just to ensure that they don't have any sort of more substantial anaphylactic type reaction. If they don't experience only hives, but after eating eggs or egg-containing foods, the person has other symptoms like cardiovascular changes like hypotension or respiratory distress, including things like wheezing, or they have nausea and vomiting, so GI symptoms, or their reaction requires epinephrine or emergency medical attention, you're specifically going to want to only administer the recombinant influenza vaccine product. So again, that cell-based product, which is going to contain no egg-based products. And again, that's only if the person is between the ages of 18 and 49, because that's the age group that the product is licensed in. If they're not between the ages of 18 and 49, so you don't have the option to administer the recombinant influenza vaccine product, you're going to want to refer them to a physician with expertise in managing allergic conditions for further evaluation to determine if they can receive a product or if there's alternative recommendations. So with the advent of this new recombinant influenza vaccine product, we have some additional recommendations in terms of using that product in patients who have a history of an egg allergy. So this next slide, as I mentioned, I wanted to include abbreviations, and I think there have been some changes in the abbreviations that are used in the recommendations that have come out from the CDC and ACIP. And the reason is because now we have more products. So hopefully these abbreviations, this slide will help you to understand what we're talking about during the next 3 slides, where we talk about all of the different influenza vaccine products that are available for this season. So as I mentioned, TIV, which stands for Trivalent Inactivated Influenza Vaccine, is now going to be replaced with IIV, which stands for Inactivated Influenza Vaccine. So IIV is now your typical vaccine that we've talked about in the past for TIV. RIV, which we talked about on the previous slide, is a recombinant hemagglutinin influenza vaccine, and that's a vaccine that's produced in insect cells, so it doesn't contain any egg, and that's why we prefer it in our egg allergic patients. LAIV is still our abbreviation for live attenuated influenza vaccine. That's our intranasal immunization. And so LAIV, IIV, and RIV really denote our vaccine categories. So all of our immunizations for influenza fit in one of these 3 categories. Then what you'll notice after is there's a numeric suffix that's after the full mnemonic for the vaccine categories. And that number indicates the number of antigens in the vaccine. So It will either be 3 or 4, and so our slide that contained our information about our strains, if it contains 3, it's those first 3 strains that were included on that slide. If it's a 4, it's going to include all 4 of the strains that were included on those slides. So that's how we're denoting something that's a trivalent product versus a quadrivalent product. And then the last item that you may see, the prefix CC, it indicates a cell culture-based vaccine. So we do have one new recombinant hemagglutinin influenza vaccine, the RIV product, that's Flublok. We also have an inactivated influenza vaccine, which is a cell culture-based vaccine produced in cells and not in chicken eggs. And that specific product is going to be Flucelvax. So we'll talk about that specific product on the next slide. So those should be all of the abbreviations that you should need to know. I think just taking a quick look at this and making sure you fully understand what the new abbreviations means would be helpful, just so you don't get yourself confused when we get into the next couple of slides talking about the specific products. So we've made it through our first objective, the recommendations from ACIP in terms of who should be immunized, and then thinking about 1 versus 2 vaccines for our younger group of patients, and then thinking about what we should do for our patients who have that history of an egg allergy. The next 3 slides are going to be tables which show you the available vaccine products and their specific indications. And really the indication is by age. So just to orient you to the table, they're all set up the same way. In the far left-hand column, it's the vaccine category. So it's going to be either inactivated influenza vaccine, that's trivalent and standard dose. We'll also have inactivated influenza vaccine that's trivalent and high dose. Then we'll have our quadrivalent vaccine, which is standard dose. We also have our recombinant influenza vaccine, which is trivalent, and our live attenuated influenza vaccine. So the vaccine category, which we talked about in terms of abbreviations on that previous slide, is what you're going to see in that left-hand column. The next column is going to be the trade name. After that, it's the presentation. So how does it come? Does it come as a single-dose prefilled syringe or a single-dose prefilled vial, or is it also available as a multi-dose vial, just for your general information? I also have the mercury content. We're not going to spend a lot of time talking about mercury, but it is something that comes up in terms of parents being concerned about mercury causing autism. Certainly we know that there's literature saying that it doesn't, and most of the vaccine manufacturers have replaced mercury with another product that's really a preservative to help preserve the product. Mercury is not present in many of our vaccine products, but just so you know which vaccine products do contain mercury, I have that up there for you. The ova-albumin content is going to be the next column, and ultimately that's going to tell you the amount of, so ovoalbumin is really the amount of egg, essentially, that's in the vaccine product. It's a very small amount that's in each of the vaccine products. The age indication is in the next column, just so you have a general sense as to who it's been approved in, and then the route of administration is in the last column. So on this first slide, I think the things that I will point out are just that all of these products, for the most part, are available as both a single-dose prefilled syringe as well as a multi-dose vial, the majority of them. In terms of when I have 2 numbers for the mercury content, the first one is for that single-dose prefilled syringe, which in general typically contains significantly less than the multi-dose vial, if there's any contained in the multi-dose vial. Both of those numbers are up there for you. And then there are differences in the age indication for each of these different products, so just something to be aware of. All of these are administered intramuscularly, and they should be administered in the deltoid as the preferred location. Now, infants and younger children, the location that you're going to want to give the IM injection is the anterolateral thigh, so it is different. Now, Flucelvax, I don't have any information in the ovoalbumin content. It's actually not provided in the package insert. However, the amount of ovoalbumin, this is our cell-based inactivated influenza product that's brand new to the market this year, and I do have a slide with additional information on that vaccine product a little bit later. The ovoalbumin content is less than a fraction per 0.5 ml dose. So a very small amount of egg contained in the product. However, because there is a fraction of ovoalbumin, it's not the preferred product in our egg allergic patients. So those are the things that I'll point out on this particular slide. In terms of this next slide, again, it's set up very much the same way. You have 2 additional standard dose vaccine products. I also have your Fluzone intradermal product on this slide, which is a pre-filled microinjection system that's given intradermally and is specifically indicated for those between the ages of 18 and 64 years. We've talked about Fluzone intradermal in depth in the past, but if anybody has additional questions about it, we can certainly talk about that at the end of the presentation. Now you'll note that for Fluzone and Fluzone intradermal, I don't have any information specifically on the ovoalbumin content. These products don't specifically contain the information in their package insert, and so it was not included in the information provided by the CDC and the ACIP in their nice tables that they've put together. However, they're produced by Sanofi Pasteur, and you can certainly call and get the specific amount of ovoalbumin. But these products do contain ovoalbumin, so they would not be the preferred product in our egg allergic patient. Also on this slide is the Fluzone high dose, and we'll talk about what it means to be high dose versus standard dose in a few slides when we specifically compare our products. This product is specifically indicated in those over the age of 65. It's not preferred by ACIP, but it is an alternative option for our elderly patients. We'll talk about why using high dose might be beneficial in our elderly patients. We do have several quadrivalent products on the market this year, FluRix, FluLaval, and Fluzone. I think what you're going to see going forward in the future is that really all of our products probably are going to switch over to quadrivalent products, and you'll probably see the trivalent products go away is my guess, but these are the quadrivalent products that are available for this year. There are 3 different products available. Fluzone is indicated in those over the age of 6 months. FluRix and FluLaval are indicated for those over the age of 3 years. They're all administered intramuscularly. And I think the nice thing is if you wanted to use quadrivalent vaccine for your patients, it is available for all the age groups that you would potentially be vaccinating. So somebody really is very insistent on getting quadrivalent, it's possible to give it in all those age groups. We do have products that have been approved for each age group. Our last table containing information about our available vaccine products. So now these are our recombinant influenza vaccine, which is Flublok, a brand new product this year containing no ovoalbumin. It is available as a single dose vial. It also does not contain mercury. Of note, it's only approved for those between the ages of 18 and 49 years, and it is administered intramuscularly. So the same what we would do with our other inactivated influenza vaccine products. Again, this is our product that's preferred in our egg allergic patients. And then finally, we have our live attenuated influenza vaccine, which is FluMist. So FluMist has replaced their trivalent product with the quadrivalent product. The trivalent product is not available anymore. And it is a pre-filled intranasal sprayer. It's 0.2 mL, no mercury contained in the immunization. And it is indicated in folks who are between the ages of 2 and 49. It is administered intranasally. So now that we've reviewed these tables and we have some idea about all the different influenza vaccine products that are available to us, let's go into a little bit more detail and talk about some of the specific information about some of our newer products. So we're going to start out by talking a little bit more in detail about our trivalent influenza intradermal Fluzone vaccine, so the intradermal inactivated influenza vaccine product. This was licensed by the FDA in May of 2011. And the idea behind the development of an intradermal vaccine was to offer an additional route of administration while also increasing vaccine production, since the ACIP had increased the patient population for whom an influenza vaccine is recommended. So that was the idea behind the development of this particular vaccine product. Specifically, it's indicated as a single dose for people between the ages of 18 and 64 years of age. And similarly to our intramuscular vaccine, it should be administered over the deltoid muscle. It's a little bit different in that it's a lower amount of strain in each dose. It contains 9 micrograms, whereas our traditional trivalent inactivated influenza vaccine products administered intramuscularly contain 15 micrograms of each vaccine strain. In terms of efficacy, the studies comparing the 2 vaccine products showed similar antibody titers between the 2 groups, indicating that they would have a relatively similar immune response. We don't have specific efficacy data relative to the development of the actual influenza virus itself, but from an immunogenicity standpoint, which is pretty standard for our influenza vaccine product trials, they did produce a similar immune response between the groups receiving the vaccine products. From a safety perspective, the vaccines had very similar adverse reactions. The most common was the injection site reactions, which is our most common adverse event seen with our intramuscular injection as well. So in terms of what ACIP has said about this vaccine product is it is an alternative vaccine option, but it's not specifically preferred other dosing options. So it's really patient selection in terms of if this product is going to be preferred by your patient and if you have it available to you in your particular location that you're administering the vaccine. The next product I'd like to talk a little bit more in detail about is our high-dose inactivated influenza vaccine product, and this was licensed even before our intradermal vaccine product. It was licensed in December of 2009. The idea behind this study was that as we age, our immune response is decreased, and so the thought was that by increasing the amount of antigen contained in the vaccine, it would result in a more robust immune response in our elderly patient population. So it's indicated as a single dose for people over the age of 65, and it does contain 60 micrograms of each strain, so 180 micrograms total if we're talking about a trivalent vaccine product. And this is compared to, as we talked about on our previous slide, 15 micrograms in our traditional trivalent inactivated influenza vaccine product. And so in terms of what the studies found, so the original studies were conducted a little while ago, but what they found from an efficacy standpoint is that the immune response in the elderly population was much more robust using the high-dose influenza vaccine product as compared to our standard dose influenza vaccine product. Now, in terms of how that translates into clinical efficacy in terms of preventing our elderly from coming down with the flu, there are studies that we're planning to look at that. I haven't seen any of that data yet published, but it should be available relatively soon. They were started back in 2009, 2010. So the plan was for it to be available when I initially looked at this in 2012, or it was supposed to be completed in 2012, probably with the data published in 2013, 2014. I haven't seen it yet, so hopefully next year when we talk about this, we'll have some efficacy data to talk about and not just our immune data. But the immune data does show that it's more efficacious in our elderly population. From a safety standpoint, the number of adverse events is relatively similar. There were slightly higher rates of pain at the injection site, so 35% of patients in the high-dose vaccine product group, where it's 25% in our standard dose group. Erythema and swelling at the injection site were also slightly increased in our high-dose influenza vaccine product as compared to the standard dose influenza vaccine product, but both are very well tolerated, very mild adverse events associated with these vaccine products, but slightly more in our high-dose vaccine product group, which is not to be unexpected with the higher amount of vaccine antigen strain in each of the vaccine, in the high-dose vaccine product. So in terms of what ACIP has said, it's not preferred over our standard influenza vaccine. And in terms of the cost, what I've seen is that it's approximately double that of the standard influenza vaccine. So again, I think, it's really up to the patient and just letting them know the difference between the two products. And also I think it's about availability. So what product do you have available? Do you have some of the high dose available? I'm certainly not necessarily in favor of this over the standard product in the elderly population. I think the most important part is that people are being immunized against the influenza virus. So now we can go on and talk about our additional vaccine products. So the next thing we're going to talk about is, should we be using our trivalent inactivated influenza vaccine or our live attenuated influenza vaccine? So now that we've completed our poll question, we're going to go on to talk about some additional differences between our vaccine products that are available. I'd like now to get into talking about the inactivated influenza vaccine products compared to our live attenuated influenza vaccine products. So in general, comparing the two vaccine products, in terms of the population, the inactivated influenza vaccine products, either trivalent or quadrivalent, are indicated in those over the age of 6 months, whereas our live attenuated influenza vaccine product is only indicated for those in between the ages of 2 and 49. From a content standpoint, actually these are a bit different now. So our inactivated influenza vaccine product can either be trivalent or quadrivalent, whereas our live attenuated influenza vaccine product is only available now as a quadrivalent vaccine product. We'll talk a little bit more about the difference between trivalent and quadrivalent next. In terms of vaccine virus production, there's a slight difference now in these as well. Our inactivated influenza vaccine products was previously only produced in chicken eggs. Now it's produced in both chicken eggs as well as other cell-based cultures. Our live attenuated influenza vaccine product is only produced in chicken eggs, so this would be another important difference. We did walk through the egg allergy previously in the presentation. The next big difference is the virus state. So the inactivated influenza vaccine product is just as it said, it's an inactivated vaccine product, whereas the live attenuated influenza vaccine product is cold adapted. So what does that mean? So it's based on the vaccine, the virus itself. So the live attenuated influenza vaccine virus is able to infect and replicate in the mucosal cells of the nasopharynx. However, because it's cold adapted, this means it's unable to replicate in the lower respiratory tract of the lungs because of the warmer temperatures of these tissues, indicating that it wouldn't cause active influenza disease. However, because it's able to infect and replicate in the mucosal cells of the nasopharynx, the goal is to elicit an immune response similar to that caused by natural infection, which may provide a more robust immune response, although that hasn't necessarily been shown in clinical trials. But we do know that it's safe to administer. It's just a difference in terms of how it elicits the immune response. Of course, the other obvious difference is the route of administration. Our inactivated influenza vaccine products are intramuscular, although we also do have our intradermal product, and our live attenuated influenza vaccine product is only administered intranasally. In terms of contraindications, our inactivated influenza vaccine product is allergy to vaccine or vaccine components, Guillain-Barré syndrome, abbreviated GBS, or acute illness. You want to wait until your patient is well to receive the inactivated influenza vaccine product. With our live attenuated influenza vaccine product, you really want somebody who doesn't have any comorbidities. So you want a relatively healthy patient in between the ages of 2 and 49. Any children under the age of 5 with a history of recurrent wheezing should not receive the live attenuated influenza vaccine product. Any child receiving children or adolescent receiving aspirin is receiving aspirin and then having influenza vaccine that's the live attenuated can increase the risk for the development of Reye syndrome. Pregnant women should not receive the live attenuated influenza vaccine product, nor those with egg allergy or Guillain-Barré syndrome. So these are some general differences between the two products. Thinking about it from an efficacy standpoint, there was essentially meta-analysis that was conducted taking a look at the live attenuated vaccine product compared to specifically our trivalent influenza vaccine product, because that was available at that time, and looking at the efficacy. The way this graphic is broken down is the studies that were conducted in children are in the top part of the graphic. The adults, it's actually really in the bottom 3/4 of the graphic, so those between the ages of 17 and 49, and adults over the age of 60. There's only one study, so that's the very bottom study represented by this graphic. And so what you can see is that in children, the studies actually showed that the live attenuated vaccine product was more efficacious, with none of your bars crossing 1. So in terms of your adults, those between the ages of 17 and 49, the vaccine products are very similar in terms of their efficacy, and those over the age of 60, it's not approved in that population, so I don't think it's really necessary to get into that data. But really where it's more beneficial is those younger patients between the ages of 6 months and 18 years. And as we have already discussed, it's approved between the ages of 2 and 49 in the relatively healthy population. So the place that I would think about using a live attenuated vaccine product is really in my younger population. I think once you get over the age of 18, the data is a bit more inconclusive, and really the reason I would use the live attenuated product is for somebody who really has a fear of needles and doesn't have any other contraindications to receiving the live attenuated vaccine product. From a safety standpoint, the most common adverse events are with the inactivated vaccine product are the injection site reaction, fever, and muscle aches. With the live attenuated influenza vaccine product, we mostly saw runny nose, nasal congestion, as well as low-grade fever, decreased appetite, sore throat, cough, and headache. So a few more constitutional type symptoms associated with the live attenuated vaccine product, but all were mild, transient, and really of minimal clinical significance. So from a safety standpoint, there is a slightly different side effect profile, but really both of them are very well tolerated. I think the next important piece to talk about is that, and I think this comes up a lot, is the issue of viral shedding with the live attenuated vaccine product. So there was a study done taking a look at the viral shedding associated with this product. What they showed was that about 30% of the subjects evaluated demonstrated viral shedding. The peak of that viral shedding occurred about 2 days after receiving the vaccine. And undetectable levels of viral shedding were achieved by day 10 in children between the ages of 5 and 8, and by day 6 in adolescents and adults. So a longer shedding period in the younger children. But I think in terms of thinking about this viral shedding is that really there have been no studies showing that people have actually developed influenza vaccine as a result of this viral shedding. So it does occur, but there have been no documented cases of influenza that have been as a result of viral shedding. And as you can see, the peak, the greatest amount, is 2 days after receiving the vaccine. So I think viral shedding, yes, it does occur, but in terms of the infectiveness of the person receiving the live attenuated influenza vaccine product, that data has not been substantiated in terms of actually causing disease. So the last slide is just advantages of the live attenuated influenza vaccine product over our inactivated viral product. So it is a needle-free administration, there is the potential for herd immunity, and there is the ease of production associated with it. Although we do have some changes that have come to our inactivated vaccine product that may potentially get rid of some of those advantages, really just the ease of production advantage. Our inactivated influenza vaccine product, certainly we do have the intradermal product available, but really not a lot of differences in terms of advantages. Those are still really the advantages of the live attenuated vaccine product over our inactivated vaccine product. So the last item that we need to talk, or we have two more items relative to vaccine products that we need to talk about. So trivalent versus quadrivalent vaccine. So the big reason for the development of the quadrivalent influenza vaccine is that there are two antigenically distinct influenza B lineages. They are the Yamagata and the Victoria lineages. Basically, the vaccine contained one or the other, and when you were immunized against one lineage, it provided limited or no cross protection against the strain from the alternative lineage. So during the past decade, about half of the influenza B lineages have been mismatched, essentially leaving someone unprotected against that circulating strain of the B lineage. So the idea behind having the quadrivalent is that the person is then protected against both lineages. In terms of data substantiating an increased benefit, the studies really have shown mild increases in benefit, but I think it depends really on our ability to match the potential circulating virus strains in terms of the vaccine and those that are circulating in the actual population. So really I think that this issue is here this year, but I think it's going to be less and less. I think all of the vaccine projects are really going to move to be quadrivalent, and I think there's not a great enough benefit to say that you need to give quadrivalent to everyone. I think a lot of it is going to depend on what you have available at that time when the person comes into your store. So I see the benefit of the quadrivalent, but I don't think it's enough to necessarily wait to only give your patients quadrivalent vaccine. As I mentioned before, I think the importance is receiving the vaccine to be to gain some protection against influenza. So the last item that we need to talk about is vaccine production, because we do have some cell-based alternatives. So traditionally, our influenza vaccines have been produced in embryonated eggs, and so that's the reason for the egg allergy discussion. The embryonated hen's eggs, they've been effective and used for years, but they have several downsides, which is why the cell-based alternatives have come into being. So our two cell-based alternatives are FluCellVax, which was licensed in 2013. It's indicated as a single dose for people over the age of 18 and is administered again over the deltoid muscle. Same contents as our other vaccine, inactivated vaccine products that are standard dose, and it is an alternative vaccine option. It's actually prepared from virus that's propagated in a Madden-Darby canine kidney cell, and so that's the potential benefit of FluCellVax. You saw it located in the table when we talked about the difference in products available this year. It does have a small amount of ovoalbumin, but significantly less as compared to our other products. Our next product is FluBlock, again licensed in 2013. So indicated in as a single dose for people between the ages of 18 and 49. Same administration over the deltoid muscle, same contents. It is an alternative vaccine option. And you saw when we talked about egg allergy, this is the preferred vaccine product in patients with an egg allergy because it doesn't contain any ovoalbumin. So I wanted to just very briefly talk to you about vaccine production and the advantages of cell-based vaccine production over embryonated hen's eggs. So embryonated hen's eggs have been used for the production of effective vaccines for years. Fortunately, they do require specialized facilities, and there is limited ability to increase vaccine production. It's also very time-consuming to adapt the candidate vaccine virus for high yield in eggs because chickens also can be susceptible to the same influenza viruses that humans are. So the advantage of the cell-based is that there's an ability to generate vaccines quickly, to increase production if necessary, and there's no egg component contained in the vaccine. So these cell-based vaccine production do provide some additional benefits over our traditional mechanisms for producing influenza vaccine, and I think it will be interesting to see where vaccine production goes in the future. I think we're going to see a lot of vaccines really go cell-based in terms of vaccine production. But we may still see that split because so many companies currently use embryonated hen's eggs and would have already had the specialized facilities in terms of producing these vaccines. So it will be interesting to see the way we go in the future in terms of the influenza vaccine production. But we do now have some cell-based vaccine products. Okay, so we've talked a lot about the different products, and I wanted to give you a slide that's just a quick and dirty reference for comparing your different products. And so the way that I have this organized is by the abbreviations that we talked about in the beginning. So you have your inactivated influenza virus, that's the standard dose, your inactivated influenza virus, that's your high dose. You have the intradermal inactivated influenza virus, and then you have your recombinant influenza virus, which is produced in the cell-based lines, and then you have your live attenuated influenza vaccine product. And I tried to pick out the things that I think are most helpful in terms of comparing the products. So specifically the number of antigens that are contained, so is it available as trivalent or quadrivalent products, which we've talked about the benefit of quadrivalent, but again, I would say really it's going to be your supply in terms of what you've got available that really should win out in terms of determining what you administer, as well as patient preference. Antigenic quantities between the different products, so the high dose contains 4 times the amount as the standard dose. The intradermal contains a slightly decreased amount of antigen. The recombinant influenza vaccine and live attenuated are the same as your standard dose inactivated influenza product. Route of administration is relatively similar between the products. Your intradermal is administered intradermally, and your live attenuated influenza vaccine is intranasal. Then the last piece that you really need to consider is the age. So your standard dose is approved for everyone over the age of 6 months. High dose is for those over the age of 65. Intradermal vaccine is only for those between the ages of 18 and 64. Your recombinant influenza vaccine is for those between the ages of 18 and 49. And your live attenuated influenza vaccine product is for those between the ages of 2 and 49 years. So I think age is going to help you in terms of determining route, the number of antigens, antigenic quantities, and then I think what comes after that is patient preference as well as what you have available to you. So hopefully everybody feels pretty confident with the different vaccine products they have available to them, and certainly I will take any questions at the end about these vaccine products. It's a lot of information to cover. So to round out our discussion about influenza vaccine, we're going to talk about the role of pharmacists in influenza immunizations. So I like to start out with just a quick fact. During the 2012-2013 influenza vaccine, almost 20% of influenza vaccines were administered by pharmacists. So this is where I like to be a little cheerleader and say, for all of you immunizing pharmacists, awesome job. And for anybody who's not currently able to administer influenza immunizations, go ahead and get out there and get certified to do that so we can increase that number even more. So the next thing that I like to talk about is just what is the role of pharmacists in pharmacy-based immunization. So how can we be involved with immunizations? And so APHA actually provides really nice guidelines, and this is a great organization if you're interested in getting involved with immunization delivery. So the first thing is prevention. Be an advocate. So motivate your patients to get the immunization. Facilitate. Be an immunizing pharmacist. If you're able to give the vaccine, you're decreasing barriers to your patients in terms of being able to receive the vaccine that they're interested in, even beyond influenza. And then actually provide that immunization. The next thing is partnership. So partner with anybody you can in the community. Partner with employers. Partner with physicians. Find partners to increase your ability to provide vaccines to patients. Provide quality immunization facilities and quality in terms of, I think, just being able to educate your patients and provide the right product for them. Document that they've received the vaccine. That's an important piece of being an immunizing pharmacist. And then empowering. So empowering patients to receive the vaccine and empowering pharmacists, other pharmacists and pharmacy students to be involved in the immunization process. So these are, I think, some of the big things you can do. Even if you're not able to immunize yourself, that's okay. There's lots of other things you can do to encourage patients and other folks in the community to really get the vaccines that they need to greater protect themselves against disease. In terms of pharmacists as immunizers, this is a really nice graphic that was provided by APHA, and I haven't seen an updated one. This was from 2011, so it's a bit behind, but I think it's pretty telling in terms of the number of states that allow for immunization, pharmacist provided immunizations, the number of pharmacists trained, and really the changes that we've seen over the years. So just to orient you, the number of states that allow pharmacists to provide immunizations is in the on the y-axis in the left-hand side of your graphic. The right-hand side of the graphic contains the number of pharmacists that are trained, and then the year is in your x-axis. The number of states and territories that allow immunizations is shown in the pharmacists to provide immunizations is shown in the green colored line, and the blue colored line is the number of pharmacists that are currently trained. So the number of states in 2011 was 52, and the number of pharmacists trained was over 150,000. That's a huge number. You can see that really there have just been leaps and bounds in terms of the number of states allowing pharmacist immunization and the number of pharmacists trained. So that's excellent. We want to see those numbers continue to increase. In terms of pharmacists as immunizers, there's a lot of differences between states, and so one of the things that I would encourage you really, if you're interested in providing immunizations, is just to get out there and find out what the requirements are and the regulations are in your state. This is the states that allow immunizations and the specific age that they're allowed to provide immunizations to the age group. So I believe there have also been some changes to this. I haven't been able to find a really nice updated graphic of this. This was from APHA in 2011, but it's very difficult to compile all of that information. So, but I think it is, telling in terms of the differences between states. So make sure you know the specific regulations for your state in terms of providing immunizations. So I know that was a quick and dirty overview of pharmacists as immunizers, but we had a lot to cover in terms of influenza products because of the number available to us. So just to summarize what we've talked about, ACIP recommends that the majority of people living in the U.S. really should be receiving the influenza vaccine. There are so many products, and really supply may determine what you recommend. We also have our quick and dirty slide which shows you the difference in terms of what the products contain, the way that they're administered, and who they're approved in. So supply, I think, may help to determine what you recommend this year in addition to some of the other things that we've talked about. Regardless of the setting that you practice in, pharmacists can play a large role in increasing our influenza vaccination rates, and we went over the APA guidelines in terms of being an advocate for immunizations in your patient population. And then finally, additional studies documenting the impact of pharmacy-led immunization programs really need to be conducted. We need to talk about the impact pharmacists are having on immunizations.